Hello everyone, my name is Dan Marsala, as you probably know from if you've seen my other videos. This is our Week 3 presentation on mechanical ventilation and the circulatory system, and more importantly, how it impacts the circulatory system. So why is this an important topic? So mechanical ventilation, obviously, as we know, is an important role of our daily jobs and a huge part of critical care. While mechanical ventilation can be beneficial and life-saving for our patients, mechanical ventilation can have some negative effects on patients as well. So these are the topics that we're going to cover in this presentation. So the effects of breathing on the cardiovascular system, normal pressures during spontaneous breathing, how these pressures change during mechanical ventilation, how these changes in pressure can negatively impact the circulatory system and venous return, and then things to look for during mechanical ventilation that are warning signs the circulatory system is being impacted. So, effects of breathing on the cardiovascular system. The very first effects documented of spontaneous ventilation were in 1733 by Stephen Hales. He actually showed that blood pressure of healthy people fell during spontaneous inspiration. Over about a century later, Kussmaul described pulsus paradoxus in patients with tuberculosis pericarditis. The Valsalva effect, this is important because this is the physical response to sustained increase in airway pressure against the closed glottis. This causes an early increase in arterial pressure and a fall in cardiac output secondary to reduced venous return. This is important related to this because it demonstrates an influence of an increased intrathoracic pressure on the right heart. And a lot of what mechanical ventilation impacts as far as the circulatory system is the right heart. So Cornan's group in 1940, he showed a variable reduction in cardiac output in volunteers receiving mask positive pressure ventilation. And again, going back to the right heart, he showed that right ventricular filling was inversely related to intrathoracic pressure. So normal pressures within lungs. During normal spontaneous breathing, intrathoracic pressure is negative throughout the ventilatory cycle. Your intrapleural pressure varies from negative 5 centimeters of water pressure during exhalation to negative 8 centimeters of water pressure during inhalation. Your alveolar pressure fluctuates from plus 1 centimeter of water pressure during exhalation and negative 1 centimeter of water pressure during inhalation. There's a decrease in intrapleural pressure during inhalation, and this facilitates lung inflation and venous return. Your transpulmonary pressure is the difference between your proximal airway pressure and your intrapleural pressure, and the greatest transpulmonary pressure can be during spontaneous inspiration is 30 centimeters of water pressure. So how these pressures change during mechanical ventilation. Positive pressure ventilation reverses the pressure of normal spontaneous breathing. So you have high intrathoracic pressures on inspiration, and these pressures are transmitted to the alveoli and the interstitial tissues. Intrapulmonary and interstitial pressure remain positive throughout your inspiration. As you remember the previous slide that we talked about, that they're negative during spontaneous breathing. So these pressures return towards a normal atmospheric pressure on expiration. When PEEP is added, intrapulmonary and interstitial pressures remain positive throughout the whole phase. So how this impacts the circulatory system. So in mechanical ventilation, inspiration-associated overinflation of the lung volumes will increase pulmonary vascular resistance. This increases right ventricular afterload, and right ventricular ejection can be impeded if tidal volumes are large. If you apply PEEP, positive intrathoracic pressure continues to inhibit venous return throughout the whole expiration phase. Positive pressure ventilation is also associated with increased salt and water retention, and this is actually due to increased secretion of antidiuretic hormone, which is caused by reduced atrial distension. So, positive pressure ventilation and pulmonary capillary blood flow. So even when we limit our peak pressures to 30 millimeters of mercury, interstitial pressures exceeding capillary pressure are produced. This actually compresses the capillary and impedes flow from the capillaries. So in expiration, a PEEP of 15 millimeters of mercury may still exceed capillary pressure and prevent recovery of normal flow. So returning to spontaneous breathing after positive pressure ventilation. When positive pressure ventilation is discontinued and the patient is placed on CPAP or extubated, your intrathoracic pressures return to normal. This causes venous return to increase as intrathoracic pressure decreases. So in those patients with impaired myocardial function, it can cause an acute increase in afterload in the presence of poor left ventricular function. So this can cause a CHF exacerbation. I don't know if any of you have ever seen it, but actually I recently had a patient that we were running a spontaneous breathing trial on, and the patient actually, from going from mechanical ventilation to CPAP with pressure support, actually had flash pulmonary edema, and we had to put them back on regular mechanical ventilation as well as diurese them to try to get some of that fluid off. So things to look for and do in the instance of decreased venous return. So the number one thing that you're going to want to look for to determine if positive pressure ventilation is causing a decrease in venous return is hypotension and tachycardia. So could drop your blood pressure, and as a result of your blood pressure dropping, you're going to have heart rate increasing to try to keep that blood flow pumping throughout the body. So if the patient becomes hypotensive, one thing that you can do is adjust the ventilator to decrease your intrathoracic pressures. So by doing this, if your tidal volume is high, you can lower your tidal volume. You can decrease your PEEP, or in the instance of volume trapping, you can reduce the respiratory rate. This will, get off that intrinsic PEEP that can be causing that increase in pressure. So I'm going to finish off my presentation with a video I found on YouTube. It's a short 3-minute video on heart-lung interaction, and I think it's just a really good presentation of actually what I talked about, so I hope you enjoy. And that's it. I hope you enjoyed and have a great week. Thank you.